present today. The title of my talk is Hypoglycemia Technology. I will just
Slide.
Hypoglycemia study group. I have the honor to chair and to invite colleagues watching to join us. You can go onto our website, you can Google, you'll see that we are welcoming new members, particularly from there is a connection. It's perhaps not as close as you would like, but you can be reliant on these methods. Prevalence in the whole type 1 population of 1 in 5, 20%. And those who have impaired awareness are significantly older. They've had diabetes for longer. And importantly, there's a very strong relationship between their awareness state and the frequency of severe events that they experience. Indeed, in type 1 diabetes, it's around 6-fold. And if you look at the graph on the right, which was a study conducted in Scotland some years ago, the longer you have diabetes, the greater your risk of impaired awareness and indeed severe hypoglycemia. And so it's duration, which is a really important contributing factor, as well as having had an episode over the previous 12 months. Now, we've always known that duration had an effect, but it's only, well, in the early 90s, we and others undertook studies to show quite why that was happening. And in this really simple study, we took a group of people without diabetes and we brought them in and tested their responses to hypoglycemia using a clump. We measured their adrenaline responses at 2.5 millimoles per liter, 45 milligrams per deciliter, and their symptom scores. And we showed that these people who did not have diabetes had a very brisk hypoglycemic response on the morning of the first study. Then in the afternoon, we brought them back and subjected them to 2 hours of slightly less severe hypoglycemia, around 50 milligrams per deciliter. And then we sent them on their way and brought them back the next morning. And you can see that these two events, because of course the test was an episode of hypoglycemia, and the 2 hours had produced dramatic changes in their ability to defend themselves against hypoglycemia, a halving of their adrenaline, and a marked reduction in their symptom scores. And these kind of studies have now been repeated in people with type 1 and type 2 diabetes and show undoubtedly that repeated episodes of hypoglycemia, and this is particularly likely in people who are aiming for tight glucose control, are going to get impaired defenses to hypoglycemia. Particularly, and this is very important, that in type 1 diabetes, you lose your most powerful automatic defense to hypoglycemia, the ability to release glucagon during hypoglycemia. And so you're very dependent on the response of the sympathoadrenal nervous system to protect you. So impaired awareness of hypoglycemia is fundamentally important. It affects around a quarter of those with type 1, and recent studies have shown around 10% of insulin-treated type 2 have the same problem. It's inducible by exposure to hypoglycemia, as I've just demonstrated. It's reversible, and I haven't time to show you these studies in detail, that if you can avoid all glucose levels below around 55 milligrams per deciliter for around 6 weeks, then you can restore at least those with relatively short duration some awareness of hypoglycemia. And its relevance is that in type 1, it increases the risk of severe episodes 6-fold, whereas in type 2s, it's probably even more important, around 15 times greater risk in those who have impaired awareness. So very important that those of you looking after insulin-treated patients with type 2 diabetes try and establish whether they have good warnings or not in the simple way that I've suggested, because it will identify those who are at major risk. Now, you can reverse it, as I've mentioned. This was one study conducted by my friend and colleague Stephanie Amiel, Ian Cranston,
led the study from King's College Hospital in London. They took 12 men with impaired awareness, type 1 diabetes. They worked very hard to prevent hypoglycemia for just 3 weeks. And when they did that, they reversed their impaired awareness, at least to a degree. And this slide shows the results of the experiments they did to show why that had happened. You'll note that they measured cognitive function during the clamp, which was done with a 4-choice reaction time test, a very simple test which can be delivered actually electronically. And you can see that the threshold for impaired cognitive function shown on the right didn't change between the pre and post periods of prevention of hypoglycemia. It was running around about 50 milligrams per deciliter. The symptom threshold, the glucose at which the threshold symptoms appeared, started around under 45 milligrams per deciliter, but at the end of the period had risen to around 55, 56. And you can see that's above the threshold for impaired cognitive function. And I hope that explains quite clearly why these people can recover their awareness. So for the final bit of my talk, I just want to talk a bit about how we can address this in real life. What can we do? Well, we can use better insulins. And this really important study, which was conducted in Denmark by Pedersen Bergard and colleagues, was undertaken to compare insulin analogs with human insulin. They persuaded these individuals with type 1 diabetes who were at risk of hypoglycemia to spend a year using human insulin and then switch to using analog insulin. And it was a randomized crossover trial, and they measured the number of hypoglycemic events. You can see on this slide the number of severe episodes broken down into the time of day and night. They showed a significant risk reduction when these individuals were using analog insulin. They reduced severe hypoglycemia by 0.5 severe episodes per patient per year, which was equivalent to a 30% risk reduction. And if you look at the bottom, you can see the timing of these severe events when they were taking human insulin and analog insulin. And the important takeaway message is that using analog insulin reduces the risk of severe hypoglycemia at night, an important observation which stands till this day. Now, the other problem with conventional delivery of insulin is that rapid-acting insulin, even with analogs, does not work fast enough. And it's quite challenging, and particularly in type 1 diabetes, to encourage patients to leave a gap between injecting and eating, which should be 30 minutes. And I wonder how many of the audience recommend to their patients that they should be leaving a gap of at least 30 minutes. In pregnancy, we say 45 minutes. And the advent of continuous glucose monitoring has shown very clearly that if patients do not leave this kind of a gap, they can't match their food to their insulin, and they will see these very sharp rises in glucose after eating. It's probably the biggest help to show how people should, if possible, use their insulin, although, of course, it's not always practical. But I just want to show you this slide, which is data from a study we published some years ago. It looked at inhaled insulin, and you can see that when people used inhaled insulin, which works within a few minutes, they could reduce the rate of hypoglycemia, both level 1 and 2, and indeed level 3. So there is a place for inhaled insulin. Of course, there have been safety issues and it's not generally available, but because it works so quickly, it is a promising insulin, I think, and shouldn't be totally discarded. What about technology? And I just want to show you a couple of slides which looks at CGM and hybrid closed loop. This is the in control crossover study undertaken in Europe published in 2016. Again, it was a crossover study. They looked at biochemical hypoglycemia in people using continuous glucose monitoring. And you'll see that when people were using CGM compared to blood glucose monitoring, they could reduce their rates of hypoglycemia at all different glucose levels. And if we looked at severe hypoglycemia on the right, when they showed actually a marked reduction in events needing third-party assistance, not quite such a big difference in severe resulting in coma or seizure or admission, but nevertheless, because of course people with type 1 tend to treat their events at home and often don't come into hospital, this quite marked reduction, I think, makes the case for CGM in people who are at risk of severe hypoglycemia and those with impaired awareness. And importantly, they were seen despite no change in hypoglycemia awareness. And that is the theme which I'm going to return to. This is an early hybrid closed loop study, the SMILE trial, 153 participants, again in type 1 diabetes. They showed a marked reduction in severe events, although there were very few. I think there was 3 events when using the hybrid closed loop, and around 15 events in total with those on CSII controls. But if you look at the number of hypoglycemic episodes here, which were less severe, still a marked reduction. Again, no significant change of impaired awareness. And I want to contrast that with the HypoCompass study led by Jim Shaw from Newcastle. We were one of the sites where this was undertaken. It was a factorial design comparing conventional therapy, blood glucose monitoring against pumps and CGM. And some patients were using pumps and CGM. And these were all individuals with frequent hypoglycemia and impaired awareness. Now, importantly, you can see when we looked at blinded CGM that we were reducing the time below 54 milligrams per deciliter. As the study went on, there was a marked reduction in severe episodes during the 12 months, the first 6 months of the study, again, as you can see here. And the intervention, which was common to all the groups, was brief education and afternoon education, followed by a weekly phone call from a healthcare professional. And it made no difference whether they were on pumps or real-time CGM. And so a good evidence that you could reduce hypoglycemia, but really importantly, this educational intervention also reduced the number with impaired awareness. And if we look at these results, you can see around 80% of those had recovered their awareness at 2 years. So there's something different between an educational intervention and technology. And frankly, we just don't know what that is. And I've mentioned education. I want to emphasize how effective it is. This is a study from Germany, published by Michael Berger and his colleagues, looked at a week's training of structured education, teaching people how to avoid hypoglycemia amongst giving them the skills to self-manage. And in the year before they underwent the training, an exponential rise in severe events with falling HbA1c, which was abolished in the year following the education. So something about education and teaching people to use their insulin safely is very important, and in many respects is a lot more cost effective than technology. And yet very few people seem to have to undergo this, which seems extraordinary, at least in my view. We have brought the German work to the UK and devised a translated version called Daphne. Again, we have shown clearly that people who undergo the education in an observational study have less impaired awareness. They recover their awareness and less events of severe hypoglycemia. And so again, a really strong suggestion that we should be providing this across all countries because it's cheap to deliver. There's been a meta-analysis, which is a bit out of date now. In fact, the International Hypoglycemia Study Group are about to update this. They've looked at educational, technology, and pharmacological interventions, and that they've shown that educational intervention was effective, improved awareness. On the whole, technology does not improve awareness, and insulins, not much evidence, but they usually exclude people with hypoglycemia. And one recent hybrid closed loop study again showed reduced hypoglycemia, time below range, but failing to deliver an increase in awareness. So what else do we have to offer? Well, there's a really interesting study just been published, led by Stephanie Emil. We participate in this. This was the HARP-DOC intervention. People who were on technology still experiencing hypoglycemia were participants in this study across the UK, 3 different centers, one in the US, in Boston at the Joslin Clinic. Educators were trained by clinical psychologists, and the aim was to look at cognitions, things that people thought about, which we think increase their risk of severe hypoglycemia. And this was just one example. They thought, well, nothing terrible will happen to me. I should be much more worried about high glucoses. And the educators were trained to address these using CBT and motivational interviewing techniques. And here are the results. BGAT is a long-standing intervention which teaches people to be much more aware of reasons, probably than repeated hypoglycemia. And if we're going to make a difference and understand this, we need to define phenotypes much better. We need bigger populations to study and conduct our interventions in large numbers. And the National Institute of Health in the US has decided to fund a very large study. It started in the autumn of last year. It's going to go on for 5 years. It includes centers in the US, UK, and Australia. And it's going to look at in a very large clinical trial to see if we can understand what is effective and indeed what is not. And so hopefully in 3 or 4 years' time, we'll be able to answer at least some of these questions. So my conclusions, ladies and gentlemen, are these. I think after 100 years of insulin, hypoglycemia remains a barrier, preventing people achieving glycemic control. I would argue that large multi-center trials, as I've just said, requiring measurement of counter-regulatory hormones, in other words, experimental studies on top of the large-scale intervention are needed to try and understand what's going on, and most important, to identify things which can make a difference.
So with the first session, let's move to the second speaker who will be joining live.
Hello.
Please give me the CV slides. Yeah. Dr. Professor Dane, he is a professor of pediatric diabetes and endocrinology, the director of the Department of General Pediatrics, Endocrine Diabetology and Clinical Research at the Bult Hospital for Children and Adolescents, Hanover Medical School, Germany. He is also chairman of the SWIT project, which is going across few centers in India also. He is a former research and fellow of Joslin Diabetes Center of Harvard Medical School in Boston. So he is also recipient of Lifetime Achievement Award of International Diabetic Federations. So had the sir joined?
I am here. Can you hear me?
Please admit, join the sir.
Can you hear me?
So I welcome Dr. Dance on behalf of Diabetes India for the session. And basically, sir will be speaking on about DKA in type 1 diabetes in low resource setting area. I think this will be very much helpful for in India, which we have a mix of resources. In tertiary care, we have a very good resource area, but if you go into periphery, the resource setting is a bit poor for us. So with this, I welcome Dr. Dance, and so the floor is all yours now.
Thank you very much for the kind words of the introduction, and sorry for a couple of technical difficulties. I hope you can see my first slide now. Is this the case, the title slide?
Yeah, it's visible, sir.
It is very good. Okay, so I'm talking about, oh, it's not moving. Oh, there it is. Okay, it is moving now. A little bit too fast. Okay. So obviously we have the good ISPAT guidelines when the resources are adequate. And I won't talk too much about the situation when we have a good intensive care unit and we have a sick child or adolescent or adult with a DKA. So if we don't have those resources, the most important thing is, of course, prevention. And in terms of prevention, I think one of the things that has been tried in many places is that you increase the awareness in the general public. You can, for example, use volunteer distributors, youth with diabetes, to schools, nursing offices, locker rooms, pharmacies, emergency facilities, that they know the 4 T signs of early diabetes. That somebody goes to the toilet very often, is thirsty, is tired and thinner, and then you should think of diabetes and thereby detecting it early and avoiding that the terrible decay is actually happening. So the next step, of course, is that the healthcare professionals need to be able to ask the key questions for relatives of extremely ill children, adolescents, and young adults. Is there any nighttime going to the toilet? Are there ants at the site of urination? Is there unexplained weight loss? If one of these questions is yes, then please immediately do a finger stick blood glucose or a urine analysis for glucose and ketone determination to make the diagnosis. And for those who have already type 1 diabetes, it is the task of us people, the healthcare professionals taking care of, to understand which patients are at great risk of having a DKA while on treatment. So those who have a lack of adherence or a lack of insulin, those where we know that they have trouble of having ongoing diabetes care, those who consume alcohol regularly, those particularly who are having a previous DKA. We know that previous DKA is one of the biggest predictors of having another DKA. We sometimes call them, maybe this is not a very good language, frequent flyers, because they come so often to the intensive care unit. So in general, young adulthood is certainly a great risk time. Now, how can we help the people with diabetes to understand what they should know and what they should look for? And what I think is important is that very often when they have nausea, when they have abdominal pain, and when they are vomiting, they think it has to do with that they had something bad to eat. And I try to tell those people with diabetes that in my care that I say, whenever you have those symptoms of nausea, it's first to look whether you might have had too little insulin right now, and that might lead to these symptoms. So you have to be sure that you don't have a DKA, and then you can think about food poisoning. And if there is any doubt, please call this phone number for help, because that's very often a misunderstanding of the patients. So then, of course, they have to know how to detect it. If they don't have any strips, very often the fruity smell is something that the others can actually detect, that there is the breath has a particularly smell of ketones. Obviously, the best way to detect it is the blood check for ketones, but we talk about limited resources. And so probably the most likely resource that we have is to measure ketones. And to measure ketones is not that difficult. So the individual should send somebody in the family to a pharmacy to get one of these ketone strips. And if you have ketone, well, then you are highly likely to have DKA when you have diabetes. But of course, we have to know a little bit more about it, because there are many other situations where ketone bodies can also be there, where it's not DKA. In particular, if you look at fasting, and for example, Ramadan for some people might be such an issue, and those who use a ketogenic diet. So you have to, of course, also to look at these things, and particularly if you use urine sticks, they detect only acetoacetate and not beta-hydroxybutyrate, like the blood strips. And beta-hydroxybutyrate is a much more sensitive and much quicker way to detect DKA, and also much quicker in detecting that there is a resolving DKA again, because the beta-hydroxybutyrate and acetic acid ratio increases in DKA from normal to 5 to 10 times the size. So depending on when you're able to do these measurements, then you can actually see kind of like a traffic light that once you have trace or small or 0.6 to 1.5 millimoles of ketones, it's important to understand that the ketones go only away with glucose on the one hand and insulin on the other hand, because you need, the German professors say, the ketones burn in the fire of glucose. So if you have kind of, again, an anabolic situation with glucose and with insulin, then the ketones will go away. So if you look at the common protocols or wallet cards, and you can have patients, most patients do have a cell phone. Why shouldn't they take a picture of one of these emergency wallets, so that they understand that they need to, in this situation, give insulin, and give more insulin than usual? That if they have a high glucose, which is typical for DKA, that is already sufficient glucose to do this change in the metabolism together with insulin, but you need more insulin than usual because you are insulin resistant in this state, and that will then help you. So what type of supportive measures are important that you have to train the people with diabetes? Well, obviously exercise can again increase ketogenesis. So no exercise when you have a high glucose, when you are unsure whether you have ketones or not. High glucose would be 250 milligrams per deciliter. Very important, do not stay alone in such a situation, because if the things go on, you might lose consciousness, you might need immediate help of somebody. Drink fluids. If you have nausea, drink it sip by sip, 1.5 to 1 liter, depending on age. And of course, if you have blood glucose measurement available, do this every 1 or 2 hours and test ketones if this is possible. The goals of therapy are very easy, of course, easier said than done in limited resource settings. Correct the dehydration, try to correct the acidosis, and reverse ketosis with insulin and glucose, restore the blood glucose to near normal, and in particular, monitor for complications, and I will come to this in a moment. And what is also important, once this episode is resolved, figure out, identify what was the precipitating event, and make sure that this doesn't occur again. So if the IV fluids are not available, there's no venous access, you have no cannula, as I said, small sips of a salty fluid, coconut water is recommended by some since it's high in sodium, can be given as frequently as possible without causing vomiting. If there is persistent vomiting or people are too drowsy to drink, these fluids can be given by a nasogastric tube, about 30% lower rate than calculated and increased as tolerated. If the person is drowsy, the healthcare professional should consider the balance between the risk of aspiration with the benefit of sustaining a circulation. One of the things I think we have to take from the guidelines. If you have then this bring this patient in an emergency setting, and it's an unexperienced emergency setting, when they see acidosis, they are very quick with bicarbonate therapy. But for DKA, bicarbonate is not recommended because bicarbonate does not transfer through the blood-brain barrier, and thereby giving bicarbonate very quickly leads to a normalization of the pH in the blood, but on the other hand, have a paradoxic liquor acidosis in the brain, and this is, of course, not very good. So you only do bicarbonate when you have a compromised cardiac contractility. Now, if you're in a resource limited setting, this might then also ask the question, can I give IV insulin or should I use subcutaneous insulin? So actually subcutaneous, or if you have a bad circulation, maybe even intramuscular insulin, you can use rapid or also rapid acting insulin injected every 4 to 2 hours respectively might be a very good possibility. And this might be a good situation. There are guidelines out there published in Pediatric Diabetes that give you a good idea that you can use subcutaneous insulin in uncomplicated mild to moderate DKA. And then, of course, you should make sure that you also administer glucose once the glucose falls between 14 to 70 millimoles or 250 to 300 milligrams in order to avoid hypoglycemia. And you start with 0.5 units per kilogram per hour after you are able to give some fluids, either through the nasogastric tube or IV. And then you can reduce this if the blood glucose is a little bit lower. So if we look at, this is of course something for you to look up. So you have two possibilities. If you use the subcutaneous route, you can of course then choose 1.15 units per kilogram every 2 to 4 hours, subcutaneous or intramuscular. If you are able to have an infusion, then it's 0.05 to 0.1 units per kilogram per hour that you are giving those infusions. Now, finally, I want to focus a little bit on the possibility of complications. And the biggest complication is cerebral edema. I'll come to this in a moment. We also have to watch the potassium. The potassium in the beginning is very, very high because there is this exchange with the bicarbonate. Although you have a very high potassium, it's actually low because of the urinary loss. So you have to replenish the potassium and have to take great care already when it's normal or even supernormal to add potassium to your infusion rate. And of course, you can end up also in hypoglycemia if you didn't watch for the glucose. You can, and fluid management, of course, is also important. Now, how do we recognize cerebral edema? If some child, adolescent, young adult has a headache that is worsening, you should immediately, your red light should go off. You should be very, very cautious. If there's any mental status, the individual is very restless, irritable, drowsy, confusion, all of a sudden has incontinence. If this moves on to neurological signs like cranial nerve palsies, those are already late signs. If the child has stopped vomiting and then starts vomiting later on, you have to make sure that this is not cerebral edema. And the first thing you do is you look for mannitol. Mannitol is not expensive. Mannitol is something that should be available wherever DK is treated. You cannot do something wrong. So if you are suspecting that somebody has cerebral edema, then simply use the mannitol, give mannitol 0.5 to 1 gram per kilogram IV over 10 to 15 minutes. And usually very quickly, you see around 15 minutes later, at the latest, that the cerebral situation of this child is improving. You can, of course, repeat it. There's also reports that you can use hypertonic saline. So these things are actually life-saving and damage saving, and you cannot do anything wrong. So whenever you are treating a DKA, you have the feeling this could be cerebral edema, use mannitol, and this will help you to save the child. So in closing, I hope I have given you a quick overlook over the possibilities also under not so resourceful situations to treat DKA. Definitely very important when there are geographic constraints and you need to initiate the DKA treatment in a center with limited experience. Try to phone or video conference support from a physician who has expertise in DKA, because if you don't do it right, this child might be have serious consequences, this adolescent. So try to get help quickly by somebody who knows how to do it. I hope I have helped you a little bit and given you some reference about how to do it. And I wish you all the best. Thank you very much for your attention, and greetings from the Hanover team.
Thank you, Dr. Dan. It was a wonderful presentation. Even though we have Q&A session at the end of the first talk, but the next two talks we're gonna have recorded. So I asked the audience if they have any questions, then or any clarifications. Our Dr. Dan is quite happy to answer that.
Good evening from India, Thomas. I don't know you are having lunch or your time. Anyway, nice that you are here. See, in type 1, you said about subcutaneous insulin. You know that in this country, the designer insulin is being aggressively promoted. The topic is in a low income setting. What is your opinion about the conventional insulin and the designer insulin in the management of type 1 diabetes?
Well, this is a difficult question. Let's put it this way. For DKA, it doesn't really matter what you use, so you can use both. Clearly, we believe that in the basal bolus, where you have a meal-related prandial insulin, you want to have a quick action. And although the scientific studies are not really very, very conclusive, in our settings, we usually use the ultra-rapid mealtime insulins, as the patients do report that they have a quicker onset of the insulin. But to be honest, I think if you need to spend money on CGM. This makes a lot of difference, much more than a designer insulin.
I hope that, like the US, you could also persuade your chancellor to lobby the no to cut down the prices so that everybody will benefit. You are more influential than us. Anyway, thanks for highlighting us. Thank you, Thomas. Maybe next time.
I hope so that I will be able to be there next time.
Pleasure, yes.
I'm very sad that I couldn't come.
I hope I didn't see like any more questions. So shall I move to the next talk? And it was wonderful hearing from you. Thank you, sir.
Thank you. Bye-bye.
Bye. So after the series of hypoglycemia talk and everything, now let's go to like about hyperglycemia. So the speaker is Dr. Guillermo E.
Hello,
Frias.
I'm Guillermo Pierres. I'm a professor of medicine. Hello, I'm Guillermo Pierres. I'm a professor of medicine at Emory.
He has received numerous teaching awards for the best clinical teacher and a mentor at Emory University, the National Award for American College of Physicians, American Association of Clinical Endocrinologists, Endocrine Society, Diabetes Technology Society, and American Diabetes Association. His research interest includes mechanism of beta cell dysfunction in minority populations, preservation of acute and chronic diabetic complications, and hospital management of patients with diabetes and hyperglycemia. To his author, he has more than 400 scientific manuscripts and books and chapters, with present over more than 300 research abstracts at the National International Scientific Forum. So with this, I would like to get the recorded talk of the sir. And basically, sir will be speaking about mistakes in hyperglycemia management. Common mistakes.
Hello, I'm Guillermo Pierres. I'm a professor of medicine at Emory University. And 34 million people with diabetes. And patients with diabetes and the annual cost of diabetes care in this country is $327 billion. But about 30% of the whole expense of diabetes care is in the inpatient care. and they don't eat much. So to prevent hypoglycemia, we'd like to cut down the dose a little bit, and then you can increase daily if needed. The recommendation to use basal bolus came from two studies that we call the rabbit medicine and rabbit surgery. This is the rabbit medicine group. We divide patients treated with sliding scale in blue and patients treated with basal bolus, and we gave 0.4 or 0.5 units per kilo of basal bolus, half basal, half bolus. And you see that if you treat patients with, these are medicine patients with sliding scale, blood glucose remain between 180 to 200 milligrams. If you treat them with basal bolus, you markedly improve glycemic control. And in these studies, we did not see differences in hypoglycemia. So it says, well, basal bolus should be preferred, sliding scale should be avoided as the single way of treatment of patients with type 2 diabetes. Then we ask, well, bringing blood glucose down is important, but can you prevent complications? And these rabbit surgery patients compare, again, sliding scale insulin versus basal bolus. And we did it here to the left is a composite of hospital complications that including wound infection, pneumonia, respiratory failure, acute kidney injury, and bacteremia. If you treat patients with sliding scale, surgical patients with admission blood glucose about 220 to 240, you have a threefold increase in the rate of complications, in particular, wound infection and acute kidney injury. So you don't only improve glycemic control, but you can prevent complications if you use basal bolus, and that's what's the rationale of this recommendation from the Endocrine Society and the American Diabetes Association. What about human insulin, NPH and regular, that are used all over the world? Or you have to use insulin analogs. And we have done 3 studies. Very briefly, I will present 2 of them. The first one is called the DIN trial that compared Deramir with Aspart versus NPH and regular. This is a treat to target of less than 140 before meals and at bedtime and in the morning. Then you see that if you increase blood glucose, increase insulin doses, you're going to reduce blood glucose in the same way. So no difference in glucose control. We also repeated the same study with glargine and glulisine compared to NPH and regular. And if you do a treat to target, so you increase the NPH and regular or the glargine, glulisine, Deramir of Aspart, you achieve the same glucose control. But of course, if you use NPH twice a day, you're going to have an increased rate of hypoglycemia compared to the analogs. Here you have 25% versus 7.6% that develop hypoglycemia. So if you're going to use NPH, you're not going to target less than 140 fasting and pre-meal. You should maybe target less than 180. What about pre-mixed insulin? In many areas of this world, like Middle East, India, Spain, Atlanta, Georgia, we have significant number of patients treated with 70-30. And we did a study in the north part of Spain with Dr. Bellido, and we compared patients, medicine and surgical patients, and we treated this with pre-mixed insulin versus basal bolus with glargine and glulisine. And you will see here that the reduction in glucose control was very similar. But unfortunately, if you do pre-mixed insulin, the combination of NPH and regular is very stiff. That's right, it's not, you cannot adjust. And the rate of hypoglycemia was significantly increased. The study was terminated early because more than 50% of our patients in Spain developed hypoglycemia compared to patients treated with basal bolus. So again, if you're going to use 70-30, you cannot target a glucose less than 140 at fasting or at bedtime. There are several basal insulin. That's right. Now we have Levemir, Glargine, Degludec. Glargine U100 is still the #1 used in the United States, but we have now studies compared with the others. Are the other better or worse than Glargine U100? So the first study compared Levemir to Glargine. And this is over 6,000 patients. We combined. So again, the recommendation is that you stop the oral agents and you start insulin. And you can, the current recommendation is that if you know if the patient is, if you don't know if the patient is going to eat, or you're uncertain, or it's going to be NPO like a surgery, you only have to give a single dose of basal. So you start for most people 0.2 to 0.25 units per kilo. And you do correction. The blood glucose high, you give sliding scales. And we adjust the basal dose using the 10, 20, 30% rule. Glucose in the high 100, you increase by 10%. In the 200, you increase by 20%. The glucose in the 300, we increase by 30% the daily dose of basal insulin. And if this is not enough, or the patient is eating well, you can do the basal bolus. Again, half basal, half bolus, starting at the dose of 0.4, 0.5 units per kilo. So this recommendation came from studies that we call Basal Plus, that included 370 patients. There were medicine and surgical patients, and what you see in here is Basal Plus versus Basal bolus. Absolutely no difference in glycemic control. In the bottom of this slide is blood glucose before meals and at bedtime. Again, no significant difference. So what we recommend, this is my favorite way I treat patients in the hospital, is that you start with basal alone, and if you need, you can progress to basal bolus. In patients with very high blood glucose, maybe require basal bolus, and most people will just go with 0.2 units per kilo. What about oral agents? So during the past few years, we have learned that in the United States, about 25% of patients are treated with oral agents. So the guideline says don't do it, but people use it. So we started thinking, what can we use? Metformin, well, I'm not sure. Lactic acidosis, kidney failure, DPP-4 maybe works. That's right. TCT is not really good. Sulfonylurea is hypoglycemia risk. And we have worked on the DPP-4 agents. As you know, they bring the blood glucose down fasting, but mainly in postprandial state. There are very little side effects. And we started doing these studies now 10 years ago with the pilot studies. And we took general medicine and surgery patients that we gave sitagliptin 1 daily, sitagliptin plus Clargen 1 daily for basal bolus regimen. And when we reported in diabetes care, there was no significant difference. Hard to believe, that's right. But the key is this. If you have somebody with a glucose less than 180, the use of sitagliptin alone here in dark brown is equal to basal bolus or sitagliptin with Clargen. There was no difference. But if the blood glucose greater than 180, especially 200, 240, please don't use oral agents because they're going to fail. So an alternative to have sitagliptin in patients with high blood glucose, we did studies comparing sitagliptin and basal bolus. We call this study the Sita Hospital trial. And we do patients with type 2 diabetes with a blood glucose between 140 and 400, treated with oral agents or insulin at a total daily dose less than 0.6. Half of the patients were treated with sitagliptin plus Clargen, and the other were treated with basal bolus regimen, multiple daily injections. And what we reported now a couple of years ago is that the mean blood glucose, there is no difference. This is daily blood glucose to the left, or glucose before meals and at bedtime. So Sita plus Clargen equal to basal bolus therapy. So we also said, well, what about other DPP-4? And so we did studies that we call LINA surgery. And we took 240 patients undergoing general surgery who were treated with oral agents or low dose insulin. And we randomized to linagliptin, 1 tablet a day, versus basal bolus, and both groups received correction doses. And what we reported is that those patients treated with linagliptin, with or without correction with basal bolus, was no difference in glycemic control. So it can be used, that's right, but there is a key. If you have a patient with glucose less than 200, the use of linagliptin resulted in a mean blood glucose similar to basal bolus. But if the glucose was greater than 200, again, please don't use the oral agents because they tend to fail. Of course, if the patient has less than 200, the linagliptin was associated with less glycemic control, or less hyperglycemia, and less hypoglycemia in these patients. So what about sliding scales? I know that for many, many years we have said, please don't use sliding scale. but about 25 to 40% of patients around the world still treated with sliding scales. So we recently entertained the question, when can you slide? When can you do sliding scales insulin? And we took 25 patients in the MRI system and we looked at admission blood glucose. If you have a patient with glucose less than 140 or less than 180, the use of sliding scales alone was associated with fairly good glycemic control. Here you have the mean blood glucose was less than 150. About 80 to 90% of patients had a blood glucose less than 180. And that is the reason why people use, or surgeons or non-diabetologists still use sliding scales alone, because it works if they're mild hyperglycemia. But if the blood glucose is greater than 180 or 250, most people will fail. So the message to take home here is that you have to individualize care. You don't have to treat basal bolus to everybody. And this is a paper we just published in the Annals of Internal Medicine. If you have a patient with mild hyperglycemia, less than 200, who had been on good control prior to admission, who is insulin naive, you can treat this patient with sliding scales or oral agent, DPP-4, or the combination DPP-4 with oral sliding scales if needed. And they do very well. 80 to 90% of patients do very well. If you have a patient that already have been treated with low dose insulin or have significant hyperglycemia in the 200-300, hemoglobin A1C 7.5 to 9, we recommend the use of basal plus. A basal plus sliding scales, or you can alternate basal with DPP-4. They do very well with this combination. As I show you, you don't have to give basal bolus to everybody. We left basal bolus for those patients who are admitted with a complex insulin regimen, high doses of insulin with significant hyperglycemia, were very sick. So this is an interesting way that we recommend individualization of therapy in the hospital setting. What about how we manage patients at discharge? So a few years ago with the Endocrine Society guidelines, we said, well, if the hemoglobin A1C is less than 7, well, you should send home patients with the same dose of insulin, the same treatment that they came to the hospital. And then we said from 7 to 9, we said increase therapy or add basal. But we never said how much basal because we didn't know. And if it's more than 9%, it says send the patient home with basal bolus. So we did studies to prove that the guidelines were correct. So less than 7, we sent home the patient, and wherever they came, 7 to 9, we gave 50% of the hospital dose. More than 9%, we gave 80%. And the primary outcome was reduction of hemoglobin A1C, and you will see here that it came down from 8.75 or 7.35. So having this protocol helped in reducing hemoglobin A1C. But what I'm showing here in the red bar, in red box, is hypoglycemia. If you send home patients with oral agents and glargine with hemoglobin A1C 7 to 9, 30% develop hypoglycemia. And if you use basal bolus, 44%. So why is that? Because there is no need to give insulin, or send patients home, especially those insulin naive, if the hemoglobin A1C is 7 to 8%. We have changed our algorithm, and we don't start newly diagnosed patients or recently diagnosed or recently admitted patients on oral agents unless the hemoglobin A1C is greater than 8. We send it home with 50% of basal. And if it's more than 10%, we get 80% of basal bolus. But most people with less than 8% hemoglobin A1C, we just send them home with whatever they came on. And of course, they can be maximized when they leave home. The other thing that we have learned in the last few years is you don't have to give insulin to everybody at discharge. You can combine, like in this trial, metformin and sitagliptin in the trial that we call sitagliptin discharge. And you see that most of these patients do very well with 3 months and 6 month therapy. Or you can use GLP-1 at discharge. And this is a paper that was just published last year. And you see that liraglutide versus glargine. We send home patients at discharge, we randomize to liraglutide 1 daily or glargine U100. There was a little learned. So there is a nice relationship between hyperglycemia in patients with diabetes and patients with no diabetes with complications. But hyperglycemia is not the cause. It favors the appearance of complications, likely because it produces inflammation, oxidative stress, and endothelial dysfunction. But we now know that having improvement of glycemic control decreases the rate of complications. Here you have the data from the rabbit surgery, that if you have a lower blood glucose treated in the basal bolus was associated with significantly less, 1/3 of the complications, especially wound infections and acute kidney injury. The other thing is that you don't have to do basal bolus in everybody. You can do basal plus corrections. So 0.2, 0.25 units per kilo is more than enough. If you use NPH, you use 0.1 twice a day. And you see that compared to basal bolus, you have the same rate. I presented data with oral agents. We have randomized controlled trials, and this is a composite of 640 patients treated with DPP-4 or DPP-4 with basal or basal bolus, and the blood glucose is similar if the patient has a blood glucose less than 180 to 200. And finally, I presented some interesting data. We're working very hard. Can we stop doing finger sticks? Can the CGM replace one day finger sticks in the hospital? We don't know. We're working on that. But what I tell you is that you can have a better visualization of blood glucose during the day, during the night, compared to point of care testing that is not usually done. And the use of CGM, at least in the preliminary data that we have, has been associated with lower rate of hypoglycemic events and time below range. We want to know in large studies if this is the same, can we decrease complications? I want to first say there is so much to learn. And second, thank you so much for the opportunities to share with you where we are in the management of inpatient hyperglycemia and diabetes. Thanks a lot.
So,
Hello, I'm Guillermo Pierres. I'm a professor of medicine at Emory University School of Medicine in Atlanta, Georgia. I'm the president for medicine and science of the American Diabetes Association.
so now we come to the last session of today's evening. It's basically about cardiac, renal, and metabolic interplay in case of diabetes. And I would love to be in this last program, but I do have to catch one more session in next hall. This is very touching to me because even I too got an global alliance with one of CARE called iCare Global Project. I'm associated with that project. So for that, now we hear the recorded version of from Dr. Eberhard Stehl. He is a professor of medicine, endocrinologist, and anesthesiologist at the Munich Diabetes Research Group, Diabetes Research Institute, to the past president of IDF, German Diabetes Association, past vice president of EASD, and also like IDF. So please play the recorded video. And so dear delegates, I would love to continue the session, and let me just be on the next hall. If it's time permit, I'll come back for the closing of the session. Thank you.
Come on. Hello, good afternoon, everybody, dear colleagues, ladies and gentlemen. It's again a great privilege to have been asked to lecture at the important Diabetes India meeting in 2023. As you can see from the title, I've been tasked to discuss type 2 diabetes, notions and implications of the cardio-renal metabolic interplay. I think a rather hot topic, important topic, as many of us believe we are witnessing a profound change in paradigm. My disclosures? Well, starting pathophysiologically, we have to understand there is something like a common soil concept. Everything seems to occur, seems to develop at the same time in parallel. And in the center, you see this risky cluster composed from insulin resistance, dysmetabolism, low-grade inflammation, oxidative stress, microangiopathy, neurohumoral factors, RAS activation, and sympathetic nervous system hyperactivity. And this is actually driving the manifestation of type 2 diabetes, but in parallel and at the same time is also giving injury to the heart and the kidney. And of course, as we know, those organs interact with each other, but the most important thing is that there is emerging fibrosis, and both at the heart leading to structural changes, diastolic dysfunction as perhaps the first sign, and glomerular and tubular injury at the kidney. Actually, there have been recent pathogenetic pathways delineated, which really act on all the organs just mentioned. On the right side, you see the pathway of oxidative stress defense interacting with lipid metabolism, but what's important here also is iron metabolism. And so the premature cell death one is looking here is called ferroptosis. And induced by hyperglycemia, free fatty acids are the risk factors. And so in parallel, we have injury to the cardiomyocytes and myocyte dysfunction, alluded to primarily early as diastolic dysfunction, then renal, tubular, mesangial, podocyte injury, nerve injury, the pancreatic beta cell leading to the development and onset of type 2 diabetes, and also the retina and the bone are targets. Now, if so, is there evidence that at manifestation of type 2 diabetes, there's also evidence for damage to the kidney and the heart? And actually, we published this a little while ago, got many comments at the time, but it's now well established, as we show here, some 40% actually, as assessed by measuring albumin excretion in the urine, have clearly injury at the kidney level, and at the same time, ECG-based assessment, and this was largely left ventricular hypertrophy in association with diastolic dysfunction. So this is really overwhelming there already at the beginning. And on top, you see the multitude of risk factors, which we all know are blood pressure, but also lipids and obesity. So this was cross-sectionally at manifestation of diabetes. Now, what about the lifetime risk of cardiovascular renal disease? A huge database. And the notion here is that 1 in 2 type 2 diabetes patients will be diagnosed with chronic kidney disease, and 3 in 10 with heart failure. And together, 4 out of 5 people with type 2 diabetes will be diagnosed with CVD or CKD or die from CV causes. Now, this has become the major issue, and as already alluded to, this probably signals a change in paradigm. Because when you look here, what are the earliest manifestations of all the complications in the countries as listed here? In blue, you see that cardiorenal disease by far outweighs early on other complications like heart attacks or stroke in red, and some 60% actually amount to this cardiorenal disease. And if present, it's really bad news in terms of all-cause death, which is more than threefold up, and for cardiovascular death, it's close to 4 times up. So it really, when we recognize it's abundant, it's very early, it's signaling bad news, and it has become the major issue in type 2 diabetes. Now, the good notion is that there is light at the end of a tunnel or a new horizon. As we all know, there are novel drugs, and showing here our latest network meta-analysis, the largest to date, more than 800 trials and close to 500 1,000 patients with type 2 diabetes. And as we all know, the SGLT2 inhibitors, they reduce, as you can see from the odds ratio, by 40% end-stage kidney disease, but also admissions for heart failure. And at the same time, they even give you benefit in terms of reducing all-cause death and cardiovascular death. And emerging and important to understand is also GLP-1 receptor agonists have a significant favorable impact on the kidney and also in terms of heart failure. This was early on a discussion, but with more and more studies in. And of course, the population studies studied in those outcome trials, it's clearly that there is also benefit for this cardiorenal effects. And for your interest below GLP-1, we have also analyzed non-steroidal mineralocorticoid receptor agonists, finerenone, famous studies, fine art studies, and other Figaro, etc. And as you see, this is a rising star again, showing clearly in people with already early kidney changes, a significant reduction in end-stage kidney disease, but also reduction of heart failure. And what's interesting in terms of severe hypoglycemia, where SGLT2 inhibitors and GLP-1 receptor agonists are more or less neutral, they reduce severe hypoglycemia. And on the right side in red, as we all know, there are downsides also related with the use of those drugs. But we have now a rich armamentarium. And the challenge now is, the task today is how we make this work for the many people out there in primary care. And perhaps one last notion, it also has become clear that the reduction in heart failure events is the same across the full spectrum of left ventricular ejection fraction, confirmed in the DELIVER study, but first shown in the Emperor Preserved study. Now, in cardiology, we have moved now to define at risk for heart failure. So these are people without signs or symptoms or structural cardiac changes, but they have an abundance of risk factors. As you see on the left, hypertension, CVD, diabetes, obesity, and other aspects. And here we focus on pre-heart failure, which is now stage B, watching out for structural changes, but also evidence of increased filling pressure. And this can be picked up early by measuring natriuretic peptides, and for ischemic heart disease also using troponin. So we have the instruments to narrow down the gap between the manifestation and the diagnosis. And previously we started to treat in stage C. Now we start to treat in stage B. Of course, we always want to intervene risk factors, but specifically here we are talking about also the introduction of SGLT2 inhibitors. And at the renal level, and this is the working concept of KDIGO, we watch for the occurrence of albuminuria, microalbuminuria. I showed you our own experience with that, but at the same time also for reduced glomerular filtration function below 60. And it's important to understand both factors are very, very important. As you can see here, they are additive or synergistic, and we have to look for both, and of course also try to intervene both. So this is a current, perhaps concept that we will soon see in the European Heart Journal, that of course we want to assess the risk by doing risk factors, but the broader concept is the important thing. On the left side, if family history of diabetes, obesity, hypertension, dyslipidemia, smoking, CVD, not only watch for heart failure, but look for type 2 diabetes in those people, because this is all occurring at the same time. And in the middle panel, the suggested biomarkers, I've alluded to that, And of course, at the end of the day, we have to take the history or assess organ complications as listed here. And now the new concept is that on one side, we do the cardiorenal metabolic management on the left side, as we all know, as diabetologists and endocrinologists. On the right side, we need monitoring, but even more important, organized the interdisciplinary care according to the clinical scenario. And not losing sight to the importance of going for strict glucose control early on, which is the paradigm of the UK PDS study. We all know the legacy effect, and you probably also know that recently we now have 44 years long evidence on the effectiveness of this, still reducing death to a significant amount and also fewer diabetic complications. And this is the model for the primary prevention. And we always have to separate these two aspects and secondary cardiovascular intervention. And in primary prevention, strict metabolic control, just to show the current evidence, meta-analysis, yes, significantly reduction of primary kidney outcomes, but also eye outcomes. And in terms of non-fatal myocardial infarction, it is less effective in secondary intervention. Actually, in most studies, it's neutral, but it works beautifully in primary prevention. So this comes to the point, why not combining the so-called glucocentric view and the cardiocentric view? And as you see, the cardiac drugs, I mentioned this, are GLP-1 receptor agonists, SGLT2 inhibitors. Perhaps in the future with early kidney changes, also the non-steroidal mineralocorticoid receptor antagonists. And then we can differentiate the high cardiovascular risk versus those with low cardiovascular risk. And it's very clear what to do at high cardiovascular risk. But it's interesting, recently, we also had the results of the GREAT study, and only 6% had established cardiovascular disease. So it's more or less a UK PDS type low cardio risk population. And here there were compared drugs we know well, like Glargine, which are neutral for cardiovascular benefit, but also for damage or downsides compared to liraglutide, glimepiride, sulfonylurea, sitagliptin. And as you see in blue, the winner actually is liraglutide in terms of reducing any cardiovascular disease, but already mentioned also reducing hospitalization for heart failure. But the older drugs, which most of them are now generic, can be used, as you can see clearly in economical considerations in those people with low cardiovascular risk. And at this point, we made in this editorial the next steps after metformin. But still, when we go for sulfonylureas and insulin, we have to watch out for hypoglycemia. And as you see, it's more pertinent for glimepiride than for the insulin. And this is also the notion of this large network meta-analysis we just published. I referred to that. And if you look for the line of sulfonylureas, you realize in red, severe hypoglycemia more common compared to basal insulin, 2 lines below, but at the same time, no risk in terms of worsening heart failure or doing any other harm to the heart, especially in terms of glimepiride. So we have come a long way. I want to summarize. We have a changing picture here, and we need to focus on this cardiorenal metabolic aspects. And I think a lot of people feel we have to train also doctors in primary care to become the specialists, at least to do the basics in this. focus on timely diagnosis of cardiorenal metabolic disorders. We have discussed the tools, tailoring the appropriate personalized metabolic therapy to the individual patient, precision medicine considering comorbidities, prognosis, patient value, and informed consent. And then regular physical evaluation and biomarker monitoring for emerging complications at least once a year, or if there are acute changes, more often as appropriate, and organizing the multidisciplinary care according to the clinical scenarios with cardiologists, nephrologists, etc., and assuring compliance with the CRM therapy. And as we know, I have listed all those, and plus attaining the targets for blood pressure and lipid control. With this tour d'horizon, also not to forget, check the feet, because especially in cardiorenal patients, these are at risk. And of course, also going to organize advanced therapy. And thank you very much, and I'm happy to take your questions.
Thank you, everyone. So the session is closed now. We can proceed for the let's move to the International Speaker Symposium.
Address the question of which interventions there's a reasonable leukemia around 50 college hospitals of a gap. They can't match their food to that. They showed here following the, and here's the result.
Other one of these questions, yes, then please immediately, but look, or you the diagnosis. And for those who have already, it is the task of us, healthcare care of, understand which patients are at great risk. You have to be sure that you don't have a decay, and then you can about food. And if there is any doubt, please help, because that's often. So then, and with drowsy, if you are able to have it, right, to get help.
Epidemiology, diabetes care for most patients with type 2 diabetes. What so if
Below, but
एक मिनट हेलो